Meet Dr. Edna Foa, one of the world's top experts on post-traumatic stress disorder, commonly called PTSD. Over the past 30 years, she's pioneered a highly effective treatment called prolonged exposure therapy, which continues to be used throughout the world as one of the frontline treatments for PTSD. Due to her research and the therapies she's developed, Dr. Foa has received numerous awards from SAMHSA and many other professional organizations. In 2010, she was honored as one of Time magazine's 100 most influential people in the world. When we interviewed her at the University of Pennsylvania's Center for the Study and Treatment of Anxiety, where she serves as director, our first question was, what sparked your interest in the treatment of PTSD?
I wasn't interested in the treatment of PTSD in the beginning. In fact, I didn't know there was post-traumatic stress disorder because my interest started in 1979, and I was in England for sabbatical. And my interest really was in a theoretical question, and that, how do people go through, and I didn't even say then traumatic event, how do they go through a very distressing event? And what is the process by which they either overcome it or not overcome it? We do have nightmares, flashbacks about negative events. Why don't we have flashbacks on positive events? I was very happy, really very happy during my wedding. I never have a flashback about my wedding. So what's the difference? So that's kind of where I started.
When Dr. Foa was in England, she worked with Stanley Rockman, a prominent psychologist.
We were talking about it. We talked about what we called emotional processing. How do you process negative events? And at the time, and that was 1979, he gave me a file with about 4 papers in it, that much. And all of it was, the papers were about rape. So he gave me a file and he said, if you're thinking about distressing event, sexual assault is a very distressing event. So here are 4 papers.
Coincidentally, Dr. Foa's previous research on anxiety included patients who were victims of sexual assault, so she already had familiarity with the symptoms, which not surprisingly included anxiety.
So I started with sexual assault, and I read a lot about it, and my interest was how do people, mostly women, but not only women, how do they get over it?
So Dr. Foa wrote a grant to the National Institute of Mental Health to study the progression of recovery for patients experiencing distressing events.
By that time, post-traumatic stress disorder was introduced into the DSM, so I knew that maybe I'm actually studying PTSD. And over that 1 to 2 years that I was kind of immersed in this topic of how do you naturally recover, I then kind of became interested in the treatment of PTSD. Remember, it was 1980. We didn't have treatment for PTSD because we didn't have PTSD.
In fact, PTSD had just been introduced into the American Psychiatric Association's 3rd edition of its Diagnostic and Statistical Manual of Mental Disorders, known as DSM-3, in its classification scheme introduced in 1990.
I did work on anxiety disorders, and I did treat people with anxiety and anxiety disorders. Among them, there were women who were sexually assaulted and had anxiety, what I called then anxiety, and symptoms that were related to being assaulted. But then, in 1971 and 72, I didn't know that they had PTSD. I thought they had an anxiety disorder. I thought they had phobias. They don't go to places that remind them of the trauma. They are thinking about it a lot. Well, that looked to me like phobia. And so I was treating them with treatment for phobias.
The first-line treatment for phobias at the time was, and still is, exposure therapy.
You treat phobia by making a list of situations that the patient doesn't go or avoid. But the situations really are safe. But because they are related to, let's say, the person was bitten by a dog, now they're afraid of dogs, but they also are afraid of going to parks because there may be dogs in parks. And so it generalizes to all kinds of things that in their mind related to dogs. So you treat them with what we call in vivo exposure. Exposure in reality, where you make a list and you start from things that are more easy and you get to things that are more difficult. So when I go to PTSD, I said, well, that's kind of similar. Why don't we just use exposure therapy? But then there was a problem because in phobias, the people are not haunted by the image of what happened to them. And many people have phobias that they don't know where they were coming from. There was not, at least 50% of people who have phobias don't identify an event like being bitten by a dog. They just have phobias, and they don't know where they're coming from. So you don't have a memory with phobias. Here in PTSD, you have a memory. So and the memory haunts the people that have PTSD. It haunts them in intrusive thought, it haunts them through nightmares, it haunts them through flashbacks and avoidance, and so forth. And so you have to take into account what to do with the memory, with the traumatic memory. So then we had to modify the exposure treatment for phobias to take into account that there is a special situation here with a traumatic memory. So that's how I started to develop prolonged exposure.
Prolonged exposure therapy, or PE, has 4 components: education, breathing, imaginal exposure, and in vivo exposure. After educating the patient about prolonged exposure therapy and PTSD, the patient is taught how to relax using special breathing exercises.
So the way that I've developed it was that we ask patients to tell the story, to tell what happened to them. And we found that the most efficient way is to say, what is the memory that haunts you the most?
This is the imaginal exposure component of prolonged exposure therapy.
The memory that comes back to you. So in the last 2 weeks, the memory that came back in flashbacks, in nightmares, in intrusive thoughts. And let's kind of work on that memory. And tell me whatever you can, whatever you remember about that memory. Now, with many people, we ask them to close their eyes when they talk about it so they don't get distracted, and so they can kind of get into the memory, both remembering not just what happened, but to get in touch with their emotions, the emotions that this memory elicits, also the thoughts that they had at the time, the feelings that they had, the physiological feeling, the bodily sensations, so that it becomes kind of not just a story that you tell the police, but that it becomes a story that has all the elements that were at the time of the traumatic event. the anxiety, maybe guilt, maybe shame, what happened, what the thoughts were there, what bodily sensation, the entire event, the entire experience. In a way, I want them to be with one foot here in the present and one foot in the past. But I do not want them to be with 2 feet in the past. So they know they're not there, but they're enough there to get in touch with the emotions. Because we do know that being in touch with the emotions is correlated with success of the treatment.
The next major component of prolonged exposure therapy is in vivo exposure, which means in life.
Which is really a fancy name to exposure in reality, in real life. So there, as I said before, that's very similar to treatment of phobias, to treatment of panic disorder, to treatment of OCD, and that is that the therapists and the patients together are making a list of situations or objects or people that they avoid, not because the situations or the people or the events or the objects are dangerous by themselves, but because they are related to the traumatic event in some way, which is not always completely direct way. People with PTSD many times are avoiding crowds, crowded places. So they will go to the supermarket, kind of 24-hour supermarket at 2 o'clock at night, which I think is dangerous. Instead of going at 4 o'clock in the afternoon when the supermarket is full of people.
In a case where a patient avoids crowded supermarkets, a prolonged exposure therapist might make an in vivo assignment to visit the supermarket at 10 in the morning when it's less crowded in order to avoid crowds. Over time, the patient will be asked to confront other situations that cause them greater anxiety. But as they discover, they can tolerate their anxiety, and that anxiety decreases as they remain in the situation for a while. As they continue to confront situations that cause them PTSD-related anxiety, they will be able to function normally. All of these components are taught under the supervision of a trained PE therapist and with the cooperation of the patient.
So we talk about nightmares, we talk about avoidance, we talk about flashbacks, to give them a framework to understand that their reactions are common. And also, it helps them not to be afraid of those symptoms.
Finally, after each session, patients are asked to revisit what they've learned to help them process their emotions.
After the revisiting, what we call the revisiting of the traumatic memory and talking about it and describing it, then we actually do what we call processing of the event. What did you learn today? Did you learn anything new? Did you get any new perspective? What does it tell you that you were anxious, quite anxious and distressed in the beginning, but then you were less so? So we kind of help them process and metabolize what happened, and with the idea that over time they are going to shift negative emotion into either positive emotions about themselves and about the world, or at least neutral.
So why does prolonged exposure therapy work?
Well, for many reasons. I mean, and they are all kind of come up together. When you do imaginary exposure, when the person does the imaginary exposure, or what we call the revisiting, And people with PTSD are really afraid of talking about the trauma. And they avoid talking about the trauma or thinking about the trauma as much as they can. Because the idea is, I won't be able to tolerate it. And then I may fall apart. I don't know what will happen, but I won't be able to tolerate it. So when they stay with the memory and they talk about it and they see that they can talk about it and they don't fall apart, then they learn that what they were afraid of doesn't happen. They're not falling apart. They are stronger than they think they are. They're learning, that's one thing they learn. They also learn that anxiety does not stay forever, or distress does not stay forever. It does go down. Right? Another thing they learn is, and that's a very important one, is they learn to actually remember what happened. And the in vivo exposure, what it does mainly is disconfirming people's ideas that the situations are dangerous and something bad will happen to them. So they go into the supermarket. Right? First, they may go into a small supermarket, then into a bigger supermarket. And first, when a supermarket is not full of people, and then and nothing happened to them. Right? And so it's really the experience of disconfirming what they thought will happen to them. And also disconfirming the idea that if they go to these places and they feel so bad, they wouldn't be able to tolerate it. So they get the idea that they are not as weak as they thought, and that the world is not as terrible as they thought. Because, yes, of course, people that have gone through a trauma, you can't tell them that the world is Pollyanna. Bad things happen. But most of the time, the world is safe. Some of the time, it's not. And you need to make a distinction, whether to go at 2 o'clock at night to, a neighborhood that is not safe. Well, probably not. Because in exposure therapy in general, prolonged exposure also, we don't put on the list of situation dangerous situation. We don't want to take away normal fears. Normal fears are good. It's the pathological fears. It's the fears of things that are practically safe. Those are the things that we want to change.
Describe the biggest challenge you faced developing PE therapy.
In a way, I did develop the program that is called prolonged exposure, but pieces of it were there right before. And so with Vietnam veterans, for example, they did some kind of imaginary exposure, not the way we do it, but some kind of imaginary exposure that was not that helpful, actually. And so, it was short, it was not long enough. That's how I called it prolonged exposure. It was not systematic enough as we do it. There was no processing after that and, talking. So it wasn't the best treatment at the time. And it was done with men, not with women. So the rape victims were given exposure therapy. Well, maybe because they were thought to be too fragile for it. And so I was the first time that actually tried exposure therapy or prolonged exposure with women, because my work in the beginning was with sexual assault women, or child sexual abuse, women who were sexual abuse as children, and then women who were non-sexually abused, attacked, physical attacks, But it was with women in the beginning. And then over time, we started to work with men and with military, but also civilian men. Find that it works for both. But so in the beginning, there was like, don't do it with women. With women, you're going to re-traumatize them. Right? And there was this, this is treatment that makes these people worse rather than better. Now, I'm not saying that we are successful with 100% of the people who are treating with prolonged exposure. Obviously, we don't have any treatment that works with everybody. But with 80% of the women, we have seen very, very good results. And about 40 to 50% actually lose the diagnosis completely. They said, well, I don't even remember that I had those symptoms. So it is quite powerful, and I have never seen anybody who got worse. I've seen people who didn't get better.
There are many stories of people who have received PE therapy and had their symptoms greatly reduced or in complete remission.
My story is that I lost a child in a tragedy, in a fire actually. It was something that really took a toll on me for a really long time. I just didn't care about myself. I didn't care about life. I didn't care about my family. I was hurting so much for my son, and I just couldn't understand why that had happened to me. Out of all the good things that I had done in my life, why this had happened to me. And this was something that just took me where I didn't want to wake up in the morning. I didn't want to talk to people. I didn't want to be around people. A lot of days I just didn't want to live. So a lot of it was me trying to hurt myself. It took me in a really dark place. It had me mentally and emotionally broken. A lot of it was me just isolating, me not wanting to deal with my family, my friends, me not wanting to face the reality of what had happened to me, not understanding why it happened, not knowing what to do from there. I really didn't have a great support system at that time. I had lost a parent, actually both of my parents within the same amount of time frame. It just was a lot going on. I didn't sleep for a really long time. I didn't eat for a really long time. It just was a lot of things that I removed myself from society. I removed myself from what was real and what was tangible. I didn't want to accept the fact of what had happened to me, so with that, I self-medicated a lot. I couldn't watch certain TV shows on TV. Anything that had to do with fires or had to do with firemen or anything with a rescue. And it wasn't until I came through the program of Anxiety for Penn that I learned that I did do everything that I could. But for a long time, I didn't think that I did enough. I didn't understand why I was still here and my son wasn't. I didn't understand why I wasn't able to save him that day. It just changed who I was. I was a vibrant, happy person. I loved people. I loved doing things. I loved being places. And it just changed me. It changed who I was, what I wanted out of life, what my future held. It changed everything about me. A lot of days I didn't want to wake up, and part of my addiction was me doing everything that I could so that I couldn't wake up. Putting myself in certain circumstances to harm myself. I've dealt with some relationships that weren't always conducive to me. I've had, some physical abuse that was, put on me. I've had to the point where I was looking for attention and love and different people that I knew that they weren't good people. I had a former boyfriend that actually set my apartment building on fire, that just destructive things that I was doing, and people that I had in my life. I've come a long way. I thank those that did hang in there with me, those that, that looked to see better things in me, that knew who I was before this tragedy happened to me, and that stuck by me. I have family and friends that have been supportive. They didn't leave me, I actually left them.
So what turned things around?
Actually, this program turned things around. It actually gave me back my life. It allowed me to deal with the pain that I suppressed for so long. It allowed me to go over that day. And, it was painful in the beginning, but a lot of it was just keep talking about it, because for so long I didn't talk about it. I didn't want to talk about it. I didn't want anybody around me to talk about it. I had exposed myself to a lot of things that were painful, but for me, I had to go back there in order to be able to move forward. If you really want to do this, it is possible, because I never thought that I would be able to wake up and feel normal again. I never thought that I would be able to actually have a life, be able to smile, be able to be happy, to be thankful for just being here another day. But if it took for me to really dig deep within myself to want to be the person that I am now, and not be that person that I felt sorry for, or that person that constantly went through those issues and those problems, needing constant therapy, needing certain medications, needing all these things that I covered up to try not to deal with the things that I need to deal with. But I do believe that if a person wants this, they can truly have it.
Sharonn, thank you so much for sharing your story. Are there any last thoughts you'd like people who are considering PE therapy to know?
It truly gave me back what I needed to be productive in society. It gave me back what I needed to be a good mother, a good wife, a good friend. And I wouldn't trade what I've been through for anything in the world. I wouldn't trade this program in for anything. I mean, it actually really, and I can't say it enough, it really gave me back my life.
Finally, we asked Dr. Foa, what lesson did you learn during your development and refinement of PE?
Well, I think that I'm very interested in mechanisms and, the processes. How does PE works? So we're doing a lot of studies, to look at, how PE works. So I developed emotional processing therapy. It's theory, but that's why I wanted to call it emotional processing therapy. And there it says that, the hypothesis was that you have to have a reduction in anxiety during the imaginary exposure, right? During the reliving, in order to get the treatment working. Well, in several studies, we find that that's not the case. You really don't have to have a reduction. You have to have a reduction over time between sessions, but you don't have to have a reduction within the session. Right? Well, that was, that's why I think maybe it's not prolonged exposure anymore. Maybe instead of doing 45 minutes of imaginary exposure, we can do only 20 minutes. And in fact, we have done a pilot study in which we find that this is the case. That 20 minutes of imaginary exposure versus 40 minutes of imaginary exposure in 1 hour of PE versus 19 minutes of PE gave the same outcome. Because all these years, we and everybody in the world, there are about at least 30 studies on PE. They were all 90 minutes. So, very exciting for me to have it 1 hour instead of 90 minutes. because then it would be easier, it would be disseminated easier. Right? So that's, but also I found that the change in the negative cognitions about myself, I'm no good, and the world is an awful place, is actually precedes the change, the reduction in PTSD symptoms. So it's kind of, a causal relationship. So you have the reduction in your view of yourself and the world precedes the reduction of the PTSD symptoms, and not vice versa, which is really another aha. Okay? So as we are doing study about what happened during exposure, what are the elements that are really important, that excites me.
Really big. I received a treatment at the VA, prolonged exposure, and what it is you talk about a specific thing that happened to you at the war. During the war, you record it, and every week, you'd listen to that recording during the week, and then the next appointment, you rediscuss it and talk about the same traumatic event again. And as I kept doing the appointments, more of the story kept coming out. I started remembering more, and then it just turns it into that. It was just, it doesn't affect you as much because you're hashing it out more and more, and you just get comfortable with that story. It's kind of hard to explain in a sense, but it really worked for me, and it let me know, the past was the past, and you don't have to let it control your life. It got me realizing that I can get out in the crowds and start living my life again.